Hi everyone. Today we are discussing a very important topic, that is glomerular filtration rate. When glomerular filtration rate is asked as an essay question, you should be writing it under these many headings. So what is glomerular filtrate? What is glomerular filtration rate? Significance of GFR, calculation of GFR, factors affecting GFR, and measurement of GFR. So first, what is glomerular filtrate and what is glomerular filtration rate is. So the plasma that transfers the glomerular capillaries is filtered by the glomerular membrane, and the resultant fluid is called as the glomerular filtrate. So it's the ultrafiltrate of plasma, and that is identical to plasma in osmolarity, pH, concentration of electrolyte and organic molecule. But the difference is that in blood there will be proteins and cells, but here in glomerular filtrate there won't be any protein or cells. And how much percentage of renal blood flow is filtered in this way? 1/10 of the renal blood flow will get filtered as the glomerular filtrate. Next, what is glomerular filtration rate is. The amount of glomerular filtrate formed per minute in all nephron of both kidney. So all these points should be there, per minute in all nephrons of both kidney. So that is called as the glomerular filtration rate. So what is the normal value? It comes around 125 ml per minute, and that is equal to 170 to 180 liter per day. And this glomerular filtration rate is proportional to the body surface area. Normally, the body surface area of a 70 kg man is taken as about 1.73 meter square. So GFR we should ideally tell us 125 ml per minute per 1.73 meter square. And in women there is slight decrease, 110 ml per minute per meter square. So is there protein in urine? We said in glomerular filtrate there is no protein. So how there will be protein in urine? Normally there is little amount of protein in urine, that is about 100 milligram per day. So from where it is coming? It's coming from the shed of the tubular cell. And if there is albumin present in the urine, it's called as albuminuria. And if there is protein in urine, it's called as proteinuria. So this is actually a disease condition. So normally there will be very less amount of protein in the urine, that is 100 mg per day. So if more amount is present, it's called as the proteinuria. That occurs due to damage to the membrane or to the because of the loss of the negative charge of the glomerular membrane. We discussed about the filtration membrane. There we have already said proteins are not filtered, so just go through that one. So if there is damage to the membrane or loss of negative charge to the membrane, there will be loss of protein in the urine. What is the significance of GFR? Why we are so much concerned about GFR? Because a fall in the GFR may be the first sign of a kidney disease, or it may be sometimes the only sign of a renal disease. That means fall in GFR will be the only sign of renal disease. So it is very important to see whether GFR is normal or not. So how can we calculate GFR? So this is based on the Starling forces that we have already discussed in the hematology. So there are two types of forces that is acting, that is hydrostatic pressure and the oncotic pressure. So there is a hydrostatic pressure both in the glomerular capillary as well as in the tubule, and that is denoted by the letter P here. And oncotic pressure is present both in the glomerular capillary as well as in the tubule, and that is denoted by the letter pi here. So PGC is the hydrostatic pressure in the glomerular capillary, pi GC is the oncotic pressure in the glomerular capillary, PT is the hydrostatic pressure in the tubule, and pi T is the oncotic pressure in the tubule. So which all forces are helping in the filtration? So filtration means from the glomerular capillary it's entering into the tubule. So which all forces helps in the filtration? So PGC is helping in filtration and pi T is also helping in filtration, whereas PT is opposing filtration and pi GC is also opposing the filtration. So PGC is trying to push the water or fluid into the tubule and pi GC is pulling water back into the glomerular capillary, and PT is pushing the fluid from the tubule backward and pi T is helping to pull the water into the tubule. So PGC and pi T are helping in the filtration, whereas PT and pi GC are opposing the filtration. Okay, so now how we can calculate GFR? So GFR is given by the formula Kf into PGC minus PT minus pi GC minus pi T. So PGC and pi T, these two are helping in the filtration, whereas PT and pi GC, these both are opposing the filtration. So PGC minus PT minus pi GC minus pi T. So this is together called as the net filtration force or NFF. So what is KF? KF is the filtration coefficient. So what it is, we will see in detail. So what all are the factors affecting GFR? So from the formula itself we can say what all the factors are. So first one is the filtration coefficient, glomerular capillary hydrostatic pressure, tubular hydrostatic pressure, glomerular capillary oncotic pressure and tubular oncotic pressure. Then other things, sympathetic stimulation, renal blood flow, diameter of afferent and efferent arterioles, local hormones and autoregulation of GFR. So first coming to the filtration coefficient. So this filtration coefficient is a constant and it depends upon area of the capillary bed and the permeability of the filtration barrier. So area of capillary bed and the permeability. So what all will affect the KF area? So mainly it is controlled by the mesangial cells that are surrounding the glomerular capillary. So when the mesangial cells contracts, this will decrease the capillary bed area. So this mesangial cells can alter the area of the capillary bed. And what all can produce mesangial contraction? Adrenaline, endothelin, thromboxane A2 and angiotensin II can cause mesangial contraction, whereas ANP, prostaglandin E2 and dopamine can produce mesangial relaxation. So with the contraction and relaxation, it can alter the area of the capillary bed. Next, affecting the permeability, KF permeability. So this permeability of renal capillary is about 50 to 100 times that of the skeletal capillary, and it mainly depends on the size, shape and charge of the substance that is passed through this membrane. So the molecular weight of the substance is less than 10,000, that means it can be easily filtered, and also slender molecules are easily filtered. But the molecules with negative charge, it is very difficult to filter. So we already discussed that one, right? Negative charge particles, it is difficult to filter through the membrane, whereas the molecules with positive charge and are neutral, they can be easily filtered. So it mainly depends on the size, shape and electric charge of the substance. Now neutral substance that are less than 4 nanometer, that means the size is very less, so it can be freely filtered, whereas neutral substance between more than 8 nanometer, that is almost zero. Neutral substance more than 8 nanometer cannot be filtered. Albumin, that is around 7 nanometer, so it's poorly filtered. So usually albumin will not be present in the urine at all. Increase in the thickness of the diffusing membrane can occur in long-standing diabetes and hypertension. So what will happen if thickness increases, permeability will also decreases. So there won't be much filtration at all. So that's a complication of diabetes as well as hypertension. So we already said negatively charged particles, that is anionic substance, are not much filtered, whereas neutral particle and positively charged cationic particles can be easily filtered through the filtration membrane. Next factor is the hydrostatic pressure in the glomerular capillary. So the hydrostatic pressure in glomerular capillary is usually greater than capillaries in other area, and it comes around 45 millimeter mercury. So what all can change this hydrostatic pressure? So arterial pressure, afferent arteriolar resistance and efferent arteriolar resistance. These factors will affect the hydrostatic pressure. So when the arterial pressure is more, hydrostatic pressure will be more. If the afferent arteriole is contracted, that means less amount of fluid is coming to the glomerular capillary, that will decreases the hydrostatic pressure. Whereas if there is a contraction of the efferent arteriole, that means less amount of fluid is going back from the glomerular capillary, so the hydrostatic pressure in the glomerular capillary will increase. So the contraction and relaxation of afferent and efferent arteriole can change the hydrostatic pressure in the glomerular capillary. Next factor is the hydrostatic pressure in Bowman's capsule. So it is usually about 10 millimeters of mercury, and this will change only in disease condition. So it can be increased in ureteric obstruction. So if there is ureteric obstruction, that means urine is not passing out normally, so there will be more amount of fluid in the tubule, and so that will increases the hydrostatic pressure in Bowman's capsule. Next, change in the capillary oncotic pressure, that means a pi Gc. So it comes around 20 mmHg, and usually there can be a change in the capillary oncotic pressure that is occurring in disease condition. So when there is a decrease in the plasma protein, that will reduces the oncotic pressure, and that usually occurs in burn conditions. Next is a increase in the plasma protein condition. So increases the pi Gc. So that will occur usually in dehydration. That means large amount of water is lost. So there will be increase in the comparative increase in the amount of plasma protein, and that can increase the pi Gc. Next is the tubular oncotic pressure. Tubular oncotic pressure is usually 0. What does it mean? Because there is no proteins won't be filtered at all in the filtration membrane, so there won't be any protein in the tubule, so usually the tubular oncotic pressure will be 0. Next factor is the sympathetic stimulation. So that we have already discussed in the last class, right? So sympathetic stimulation, how it changes the arteriolar diameter. So if there is sympathetic stimulation, there will be more of contraction of afferent arteriole, so the glomerular filtration will decrease. Next, renal blood flow. So when there is an increase in the renal blood flow, it will increases GFR. Decrease in renal blood flow decreases GFR. Then change in GFR with the arteriolar diameter. So if there is a constriction of afferent arteriole, we already said there is a constriction of afferent arteriole means less amount of fluid is coming to the glomerular capillary. So what will happen? The PGC or the tubular hydrostatic pressure in the glomerular capillary will decrease, and so there will be decrease in the GFR. If there is constriction of efferent arteriole, what will happen? There will be more of fluid in the glomerular capillary, so the hydrostatic pressure will increase, GFR will also increase. But if the constriction of efferent arteriole lasts for so much time, there will be decrease in the hydrostatic pressure in the glomerular capillary because of the decrease in renal plasma flow. In that case, there will be decrease in the GFR. No need to remember that one. Just remember, if there is an increase in the constriction of the efferent arteriole, there will be increase in PGC and there will be increased GFR. there is constriction of afferent arteriole, there will be decrease in PGC and decrease in GFR. Just remember that one. Now the hormonal factors, the most important one is the renin, angiotensin, aldosterone mechanism, and another important hormone that is affecting the GFR is the atrial natriuretic peptide or ANP. So there are various vasoconstrictors and vasodilators also that can modify the amount of GFR. So vasoconstrictors mainly include epinephrine, norepinephrine, angiotensin II, adenosine, endothelin and vasopressin, and vasodilators mainly include dopamine, histamine, prostacyclin, acetylcholine and adenosine. Last one is the auto-regulation of renal blood flow and GFR. This also we discussed in the last class. So this means even when the blood pressure varies between 90 to 180, renal blood flow and GFR are kept constant. So that is the auto-regulation. And the importance is it will prevent damage to the glomerular capillary, maintains the GFR on a constant level, and helps the kidney to uncouple other function from change in blood pressure. That means the kidney can function even when the BP is varying. And mechanism include myogenic mechanism and tubular glomerular feedback. Myogenic mechanism is if there is an increase in pressure, it will cause a stretch in the arteriole, activating the stretch activated channel, and that will produces the smooth muscle contraction and thus decreases the blood flow. And tubular glomerular feedback means increase in arterial pressure, increase the pressure in glomerular capillary and thus increases the GFR. So when there is more amount of glomerular filtrate, macula densa will sense the increase in the water as well as sodium and chloride concentration in the thick ascending loop. And this macula densa will signal to the glomerular apparatus to cause afferent arteriolar contraction to decrease GFR. And this also we discussed. So drop in VP causes drop in GFR, and that is sensed by the macula densa, causing relaxation of afferent arteriole and thus raise the GFR. And it can also stimulate the JG cells to secrete renin, activating the RAS system, causing efferent arteriolar constriction, vasoconstriction in all part of the body, and thus increase VP, and also activates aldosterone, increases aldosterone causing sodium and water reabsorption, and thus increases the BP, and all this will cause an increase in the GFR. Okay, so one more topic is remaining in the GFR, that's the measurement of GFR. So that we will discuss in the next class. So we will stop here. Thank you.